is the last topic on cancer. There are 6 oncologic emergencies. They're discussed in table 12-13. Now, 2 of them are not listed on that table because they are implied. If you remember DIC presentation last semester, one of the causes mentioned was cancer, in addition to trauma as well as sepsis. The other, of course, is sepsis. Okay, so reason, it's self-explanatory. So what happens to a patient receiving treatment for cancer? What happens to the bone marrow? Okay, immunosuppressed, and will that precipitate them to sepsis?
Yes.
Okay, so therefore there's sepsis, and therefore, what's the complication of sepsis? DIC. So those 2 are implied, okay? So they're not mentioned in the table anymore. Go straight to the table. What's the questions going to be? Just like any other emergency expected on the NCLEX. So what are you expected to know and therefore will be tested on the NCLEX on any emergency? Recognizing it, so you need to know signs and symptoms. So that means not just the manifestations, but including lab and diagnostic testing. So what does the lab work show? And then correlate everything. Are you able to make up a comprehensive assessment together to identify what oncologic emergency the patient is having? What's the implication of an emergency? Life-threatening. Okay, so patients will die unless you're able to recognize these manifestations. And then accordingly, what's your first action? Notify the physician, okay, or call RRT. First is SVC syndrome, superior vena cava syndrome. Now, the first column will tell you what type of patients are at risk for this type of emergency. Now, these are patients with tumors in and around the thorax. So we're talking lymphomas, or let's say lung and bronchial cancer, or any other tumor growing around the torso. Okay, because that's where your superior vena cava is. What happens is the tumor is so large that it compresses the superior vena cava. And what will happen to the patient if the superior vena cava is compressed? Can blood enter from the upper part of the body? No. So it cannot drain. So SVC is supposed to drain blood from the arms, the upper torso, as well as the brain, correct? So manifestations would be congestion in those parts of the body. So we're talking, and then as a result, because there's less blood return, so what will happen to cardiac output here? Okay, so you'll have a collection of symptoms ranging from congestion from the upper part of the body, including the neck, right? Because blood drainage from the head is slowed down. And of course, there will also be signs and symptoms of low cardiac output. Can this lead to shock?
Yeah.
What type of shock? Did the patient lose blood?
No, it's going to be
Obstructive. Okay, this is a form of obstructive shock. So is this an emergency?
Yeah.
All right. So here are your manifestations. Again, a collection of congestion from the upper parts of the body, as well as decreased cardiac output, leading to obstructive shock. So you have facial edema, upper arm or extremity edema. You'll have distended neck veins, a severe headache. Okay, so increase in intracranial pressure as well. Edema in these parts of the body, skin tightness in the same areas. And x-rays will show dilated veins, especially the superior vena cava. And as already mentioned, there's increased ICP here. We'll learn more about manifestations of increased ICP, including visual disturbances, headache, and AMS under stroke. And these are your diagnostic findings. Actions on the third column. There's really not much the nurse can do here. But your role is what? To notify the team. So notify them, and then they'll issue orders. Okay. So as you can see here, management for, is there any emergency management available here? Nothing really. Okay. So therefore, I had a ex-girlfriend who died in Jersey, December. She died in December 2003. Yeah, 2003. She developed non-Hodgkin's lymphoma, and she was undergoing treatment, and then she developed SBC. Okay, so there's really not much we can do here because look at the treatment, radiation and chemotherapy. Can these work like this? No, this will take time. Okay, so it's mainly supportive treatment because the patient goes into obstructive shock, so we treat the shock. Okay, aside from that, the tumor compression is not easy to fix. All right, so therefore, do we want to discover this early or later? Okay, early management. Second is spinal cord compression. And because of this, it's implied. So where is the tumor here? Okay, either primary or secondary, most likely secondary tumor to the spine. So this is a metastatic tumor that causes this. So there's compression of different levels of the spinal cord leading to what would be the manifestations if your spinal cord is compressed. Okay, so there's back pain, there's paralysis, or at least weakness in the below the level of injury, right? And just as SBC syndrome, is there an emergency treatment here? Can you do something? Not much really. They may consider surgical debulkment, okay, to remove the compressing part of the tumor at least. It's not an easy fix, okay. There's just a short-term temporary fix until the patient, of course, completes treatment for the chemo and with chemo and radiation to get rid of the metastatic tumor. But manifestations are just listed just here. So again, there is radicular pain and there is also sensory motor loss. Okay, so either partial or complete paralysis below the level of the spinal cord involved. And take note that will also include bladder and bowel problems, okay? Because bowel and bladder are controlled by certain around T6 to T12. Third is hypercalcemia. Now, where did this calcium come from? This is a metastatic tumor to the bone. So once the tumor goes into the bone, the cancer spreads to the bone, it will break down calcium from the bone. So it will increase serum calcium levels, leading to the following manifestations. So if you recall hypercalcemia under hyperparathyroidism, exactly the same manifestations. This one we can treat immediately because what were the interventions available for hypercalcemia? Fluids with diuretics, correct? And then we had calcitonin, right? What else? Can we give, no, that's for hypocalcemia. This is hypercalcemia. Okay, so here are your interventions. So priority, of course, is cardiac arrhythmias. So we put them on a monitor and then we give the fluids with diuretics if they are options. So here, IV hydration followed by diuretics. Then avoid any more calcium intake if we can, and give biphosphonate drugs. Same drugs we use for osteoporosis, okay, to push the calcium back into the bone. And symptomatic treatment, because hypercalcemia does cause severe constipation, so we'll put them on stool softeners and laxatives. Any questions? Okay, last one, number 4. Take note that the other two, sepsis and DIC, are not discussed here, okay, because they're already discussed in previous chapters. TLS. Unlike the previous 3, which are bad news, this one actually has some good news to it. Which one do you want, the good news or the bad news? Okay, the good news is if you have the manifestations of tumor lysis syndrome, that means that the cancer treatment is successful. It is destroying the tumor. Okay, that's the good news. You want the bad news? Okay, the bad news is the patient may die. So what will any tumor that is destroyed spill out into the bloodstream? Tumor cells are just like normal cells, right? They contain the same thing. So what does a cell, any cell, whether it's a malignant, normal, or benign cell, contain? There's a nucleus in there, right? It's a nucleus, there's a cytoplasm. What's inside this cytoplasm? Electrolytes. Okay, so there is potassium in there, correct? So what will happen if you hyperkalemia? Okay, there will be hyperkalemia. And what will always be a byproduct with cellular death? Uric acid. Okay, so there's uric acid. So two problems here. You have hyperuricemia and hyperkalemia in severely high levels. So the patient will die from, number one, dysrhythmias. They could go into cardiac arrest. Or second, they can go into acute kidney injury from the hyperuricemia, from the acute gout. Okay, because here, yes, there'll be gout symptoms, but we're really worried about the kidney here. Okay, the patient will go into acute AKI like this, okay, because of the severely high uric acid levels. You all finished hyperkalemia last semester as well as hyperuricemia under gout. That was the last topic in your 241 course. So same manifestations and interventions. All right, I won't repeat them. Any questions? So review, they're mentioned here, but it's not complete. So I encourage you to go back to the fluid and electrolyte chapter for the complete management of hyperkalemia, ranging from calcium gluconate to sodium bicarb to regular insulin IV with dextrose to sodium polystyrene sulfonate. And there was a new drug, Patiromer, mentioned in this edition. Okay, and of course, don't forget hemodialysis. Okay. And of course, priority is cardiac monitoring because of hyperkalemia. And as far as hyperuricemia, you know allopurinol, right? And then there's colchicine as well. And then include nursing responsibilities when giving those drugs. Any questions on the emergencies? All right. Don't forget again to add DIC and sepsis here. That's it for cancer.